80% of women who go into menopause have life disruptive symptoms. And I always consider that to be an advantage because they're so disruptive that these women ask, I got to do something about this. What's going on here? I got to find a solution to this. And they wind up on hormonal treatment, and it's great. They got motivated to do it by the duress of these symptoms.
All right. Well, it's a real pleasure to have Dr. David Rosensweet on again on the show, and he's one of my favorite guests here, and it's been a while. So welcome, Dr. Rosensweet.
Thank you, Zora. Good to be here again.
It's great to see you again. And we have three other episodes that we've recorded. And we covered a ton of that and many of the basics as well. But today I want to go a little bit deeper into some of the newer topics. But before we do, I want to start with your thoughts on that recent FDA panel that there were a bunch of menopause experts on there, and they were fighting to remove this black box warning on vaginal estrogen. And to explain what the black box warning is, the little pamphlet as your medication, any medication you have, and it has all these warnings. And so we need to remove that. And I would like to know if you watched it and any thoughts on what we saw.
Yeah, I thought it was remarkable and a first step. And bless them for taking the first step. Dr. Macri put together a panel that was going to be bold enough and aligned enough and credentialed enough to take the first step. And they didn't take all steps that I would like to see. There's many more, but it was the big one. And ever since the Women's Health Initiative, as you know so well, in 2002, the FDA in every package of pharmaceutical hormones, there's an insert, and right at the top of the insert, it's called a black box warning, and it's false information. Yet it's been part of what scared so many women away from using the hormones that they need very, very much. I was about to use the word desperately.
Mm-hmm.
For many, that it is. And it even went so far, and Dr. Macri pointed this out, that a lot of women, even if they could get a prescription for hormones from their provider, who was also scared, when they got home and they open up the box and they see the black box warning and their spouse sees the black box warning, they both decide, no way, I'm not taking a risk for breast cancer. So the black box warning warns women if they take estrogen, they're at higher risk for breast cancer, which is totally false. The opposite is scientifically so. Women who are treated with hormones in menopause are at less risk for breast cancer, heart attack, and stroke. That's the actual science. We elaborate on it. Lots of folks have elaborated on. It's creeping into mainstream consciousness. But meanwhile, that panel came out very strongly, unanimously, and very clearly, look, stop, get rid of that black box warning and stop scaring women. It's a travesty to scare women against the very thing that can make such a profound difference in their life and well-being and health.
Yeah. Dr. Rachel Rubin, her statement of your black box warning nearly killed my mother, like that was pretty
Yeah.
powerful. I was like, wow. To think, and it is true how
Yeah.
powerful that statement it is and how it's putting women at risk by not taking what's been prescribed to them. So that just blew me away. They got such powerhouses in that panel. It really blew me away. Like you said, there's still a lot more we need to do, but at least this, it's so clear that it's necessary to remove that. Do you have any idea if, what they look at, the FDA, is it when do they make a decision? And then when would that, if they
I don't
agree,
know
when would
that.
that label be taken off?
I know. The final decision, as far as I know, has not been made, and we'll see. Well, there's endless desks to pass this on to. There was another significant suggestion there by a real thought leader in the world of hormones, Dr. Kelly Casperson, who made a strong point for having preparations of testosterone made for women
Yeah.
and not have to off-label male prescription testosterones
Mhm.
because there's more testosterone in a woman than there is her strongest estrogen, estradiol. And
Mhm.
it's so critical for the maintenance of muscle. what gets women into nursing homes, canes, walkers, wheelchairs, assisted living, diapers, 80% of the women in nursing homes are there because they lost their testosterone.
Yeah. Yeah.
And there's other reasons just related to the loss of estrogen as well. So I was delighted to see Dr.
That was
Kath really come out strongly on that one.
Yeah, because you weren't expecting the testosterone piece. And then she's right, because in most countries, there's a few that do have formulations for women, but most countries, what people are trying to do, women are trying to do, is take a little dab of a male formula. And you don't know how much is in that you're supposed to take a tenth, or there's very little way to measure. And you don't want to overdose testosterone either. So it doesn't make any sense that yeah, we're trying to use a man's formula for our own biology. Why don't we just remove this? I guess we can't have the reason, I guess you can explain better than me, the reason why there is no female hormones or testosterone is because something to do with the Olympics and doping and all this stuff. No,
Well,
that's sorry, that's related to the prescription. Yeah.
athletic abuse in the last century really poisoned the waters. And so relatively few number of athletes who were abusing androgens, they were taking some form of testosterone, and it was harmful. And they had
Mhm.
no business, young people taking testosterone.
Yeah.
And eventually the FDA prohibited it as made it a controlled substance.
Yeah.
So that's why it got into trouble. It had nothing to do with the beauty and amazingness of testosterone,
Hmm.
but abuse did it. And that's
Yeah.
why it became a controlled substance. And that's why it's harder to get it into popular production just because it is a controlled substance.
Yeah. It's crazy. Yeah. So, well, hopefully we will have a change sooner than later of all
Yeah.
these things. It's the first step is let's remove the black box warning for vaginal estrogen and then keep moving forward. But there were some pretty good arguments there, and hopefully we'll see change soon. But let's move on because I have some fewer questions, and we barely covered this the last time, but it is a question that I get a lot from my community, and it's the asymptomatic woman who doesn't feel menopause, and so she's on the fence because she may see, oh well, I want the protective benefits of bioidentical hormones to lower the risk of diseases of aging like osteoporosis and heart disease, genitourinary syndrome of menopause, Alzheimer's. Like there's so much out there. How are you treating or approach women or answering women in your practice with this question?
Yeah, excuse me. It's a great question because on the other side of that, 80% of women who go into menopause have life disruptive symptoms. And I always consider that to be an advantage because they're so disruptive that these women ask, I got to do something about this. What's going on here? I got to find a solution to this. And they wind up on hormonal treatment, and it's great. They got motivated to do it by the duress of these symptoms. And like you say, in the number is something like 20% of women, they're going through menopause. The ovaries have stopped producing their hormones, just like in the women who are getting egregious symptoms, but they're having no symptoms.
Or at
And the
least
comment,
symptoms that they don't are aware of. And I think, right, that's
correct.
because we were thinking of the classic five and oh no, I don't have any of those, but they're not thinking about the other 100 symptoms that are possible, right?
Yeah,
Sorry.
technically, they're silent losses that don't produce symptoms. And there's because estrogen and the other ovarian hormones, they're so pervasive. There's receptor sites in every cell of the body. And when you lose the estrogen, these women are at risk. In fact, the way we language it when we teach is there's almost a near certainty of the losses to all women, women with symptoms, women who don't have symptoms. And like you pointed out, the loss to bone. Estrogen is so critical for the development of bone. And when the first 5 years of menopause, when there's no period, women can they can go all the way into osteopenia and osteoporosis.
Mhm.
And when that bone weakens like that, all it takes is a fall to fracture a hip, for example. And I've seen worse. And for decades and decades, that was life-ending event. Women didn't recover from that. Now they get surgery, but most of them pass away within a year of that surgery.
Mhm.
Osteoporosis. Cognition. There's zillion, I haven't counted them, but there is a zillion estrogen receptor sites in the brain. And so many women go into cognitive decline, and they don't necessarily go into it in the beginning of menopause. And they're looking around, they're going, what's such a big deal about menopause? There's nothing wrong with me. But they can get that same cognitive decline. And so many women who get serious cognitive decline, as in dementia, could be rescued by taking hormones.
Hmm.
This cognitive decline can come on a little later in some women. And we can go on and on and on. Estrogen, the health of the vagina. Without adequate estrogen, there's vaginal atrophy, and there's irritation of the bladder opening, and chronic genital urinary infections. When you go into a nursing home, you see the majority of women are in adult diapers
Hmm.
because they've got bladder irritability and chronic urinary tract infections. It's just awful.
And it doesn't get better with age. It's
No,
the
it's
hot flash
worse.
that maybe eventually goes, but
No.
when other symptoms, they just get worse.
So the list is very long. And unlike, we're so common to make the statement, if you take hormones, you're at risk of blank, 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 most of which is not true. The opposite is true.
Mhm.
But the way we language it, again, I'm repeating myself, but there's a near certainty of loss of bone, loss of arterial health. You mentioned that.
Hmm.
My God, women have so much protection to their coronary arteries from estrogen. And in fact, if I can go a little further there, you never hear of a young woman having a heart attack who's still menstruating.
Yeah.
But occasionally you hear a story of a young man who never sick a day in his life, had a heart attack on the tennis court, 40 years old. And one of the things we know about a lot of these young men is they don't have enough estrogen because men need estrogen too. They're not getting the protection of the arteries. So the incidence of coronary artery disease in women is much lower than it is in young men. But by the age of 60, that incidence equalizes when the women have lost their estrogen. Half the women on the planet who leave Earth do so from some complication of arterial sclerosis, heart attack, or stroke. So the protection of estrogen, I should have put this at the top of the list.
Mhm.
And everyone experiences this. Women who have symptoms, they don't get treated, they're at risk for coronary artery disease, heart attack, and stroke. If they do have symptoms, don't have symptoms, doesn't matter. They're all at risk. So it didn't take me long to realize that the greatest concern I had for women in midlife were those who didn't have the symptoms
Hmm.
because they never got motivated. And the list that you said is some women are starting to learn, well, maybe there is the preventive aspect. But when a woman's not having symptoms, she's not necessarily tuned in ear to the railroad track about bad things that could happen.
Hmm.
So, yes, people interested in menopause realize there are all these losses. So, I'm most concerned about those women.
Yeah, I'm always say I'm most worried about the asymptomatic woman for the same reasons. And when I went to this European Menopause and Andropause Society conference a couple months ago, the presentations were clear what happens when we lose estrogen, when we lose testosterone and progesterone. And it's these horror stories, you're like, oh my gosh. But yet, the guidelines that are presented is you only give hormones to a woman if she has symptoms. And sometimes it's when she has bad symptoms, like not mild symptoms. Like it was, wow. As I was sitting in the audience and I was pretty much the only non-doctor there. And I was like, there's something wrong here. And I was a patient who also is asymptomatic. I think, well, now I know better that I do have symptoms that I didn't realize. I thought, well, I won't be able to the doctor will not give me a prescription based on the guidelines. And that's always what the problem is, that some doctors seem to be so stuck with these guidelines. And then you have other people, like Dr. Louise Newson was there. She was
Oh,
brilliant.
great.
And she
Great.
came up to the panel and challenged them and said, wait a second,
Did they
and she
give her
said
airtime?
exactly my thoughts. Thank goodness she was there because I
They,
felt
did they
so
give her the
lonely.
air? Did they give her the airtime?
They did give her the air. Everyone had a chance to stand up and make the question to the panel. And then she it was right. It was her. And then after her was like there were a couple of others who became bold enough because got to challenge them. And with her challenges, the panel was silent. They didn't
Yeah,
really have much to say
I
because,
think this
right.
brings up a bigger topic and one that you've been spearheading for years. And it's so unusual in medicine. Usually there's standard of care, everyone agrees. Talk to any ophthalmologist. They're all in agreement. Maybe they talk about the periphery. Oh, maybe this is a little better than that, but not big stuff. But the world of treating with hormones is like unlike any other aspect of medicine. Because in 2002, a time when all these specialties were properly developing, you want to get good at something, you got to specialize in it. The field is way too big of medicine. Obstetrics and gynecology, different types of surgery, neurology, internal medicine, but not hormones. Because of the Women's Health Initiative study scared everyone away from hormones. So we're 25 years behind. There is no there is no general knowledge amongst practicing physicians, and even in the major societies, they're still stuck back there.
Yeah.
How many of those physicians realized that the Women's Health Initiative study was recanted?
Hmm.
Was the opposite has emerged is what's true. There was protection. There's protection against breast cancer, heart attack, and stroke. But they don't know that
Hmm.
because they're not paying attention to it because nobody specialized in it.
Yeah.
So what this calls for, and I'm sorry to be so wordy about it, is it calls for grassroots women to take this one on. The world's not there to initiate this with you. You have to initiate it. And fortunately, in the United States, there's thousands of healthcare providers, physicians, nurse practitioners who get it. First of all, a lot of them have gone through menopause, but they really get it. And andropause, have a male doctor lose his erection, his attitude about testosterone and treatment changes quite a bit. So it still calls for grassroots there, and thank goodness you're doing what you're doing. The world still needs major waking up.
It does. It does. And you're teaching these doctors one at a time, right? With your program, the menopause method. If anybody is interested in that, I've got a link in the show notes for it. But I went through this program, thought it was absolutely brilliant. I learned so much in this program and actually we can actually cover some of the things that you did talk about because we did you did such a great job of an overview of everything that a doctor needs to do. So this is training for doctors, but I was lucky that you allowed me to take it. And it was super interesting to see the perspective of what doctors are learning. And not all of them have the privilege to learn from you, which I think is brilliant. But let's move a little bit into the DHEA. And this is sort of towards the end of the program. And some women prefer to take DHEA to testosterone, let's say, or their doctors prefer them on that. And others say DHEA doesn't even move the needle with their testosterone levels. So tell us what a woman needs to know about DHEA and if and when to use it.
Yeah, when you understand hormones at a biochemical level, you see one thing is converted to the next thing, that thing is converted to the next thing, that thing's converted to the next thing, hormonally. So it actually starts out with cholesterol. Cholesterol is converted to a substance that's converted to progesterone, that's converted to DHEA. And DHEA is converted to testosterone or and testosterone can be converted to estradiol and estradiol to estriol and estrone. There are a series of steps. So one of those mother compounds, cholesterol, pregnenolone, then comes progesterone and DHEA. So doctors have postulated, why don't you just give a woman pregnenolone? Her body will convert it to all the rest of the stuff just beautifully. Wrong. Doesn't work that way. The internal body knows how to convert what it wants. but you give the body something externally, and it doesn't necessarily do what you want.
Mhm.
So one could make a case, instead of giving pregnenolone, let's just give DHEA, and it will become testosterone and estradiol in just the perfect amounts. Wrong, it doesn't work out that way. So I learned that really early on, and I realized the best thing I could do for a woman in menopause was actually provide the hormone that she does need in amounts that replicate reasonableness.
Mhm.
Now, for that reason, we give estrogens, biased is my favorite. We give progesterone and we give testosterone. Those three, plus DHEA. We also include DHEA, but for its own right. We
Mhm.
don't try and get testosterone and estradiol out of the DHEA. One slide I have in our training program, it says, it's all coming out of cholesterol. Why don't you just give women butter?
Yeah, yeah, I
They'll
remember.
create all these hormones.
Yeah.
Now, having said that, you can get real precise if you give the individual hormones. You can't get precise if you give butter, or
Yeah.
if you give a pregnenolone, or if you give DHEA. You can't dial in a woman to what her body really wants. And
Hmm.
how do we find out what her body really wants? We replicate, we do so by symptom alleviation and also by testing.
Hmm.
So on 24-hour urine hormone tests, we can make sure that the right amount of DHEA shows up in her urine, the right amount of testosterone, the right amount of estradiol, and not something that's an oddball number. So that's why we don't give DHEA. I respect DHEA, my goodness. It's one of the most prevalent of the steroid hormones that exist.
Hmm. I think
So
some doctors or maybe practitioners who are not even doctors would say, well, DHEA is not a controlled substance like testosterone, and maybe they don't have the power to prescribe
that's right.
testosterone, that maybe they go, well, let's try that. But
If that was the only tool I had, I would agree with them.
yeah.
I would give the woman the DHEA and hope it went to where we wanted it to go.
Yeah, but yeah, that's the problem. That's it. You don't know how it's gonna do. All you can do is just then try it and test, and then if not,
Yeah.
then you got to move on. So yeah, DHEA is such an important substance as well, and a lot of people kind of miss that one when we're talking about menopause, or just it's all testosterone, progesterone, and estrogen, if anything. So, but you did mention biased, and you use. I loved that you're using biased with organic oils. This is a compounded, and we'll talk about compounded in a moment. But it's you highlighted so well how we're at least in this world of health and wellness, we're so concerned about lotions and potions and makeup and things that we put on, and we want it to be without parabens and organic. But yet, when it comes to our hormones, if we're prescribed some kind of estrogen gel, and I've had this where my doctor prescribed, and it's like a ton of gel, and I'm like slathering it all over my body, and I think, well, wait a second. What is in this base? It's a bunch of chemicals, and I just want the hormones. So that's one thing I wanted to highlight is just to people that we'll talk about compounded and why it's important there. But you also talked a lot about biased, and biased is usually, I guess, it's 80% estriol and 20% estradiol. And these are different types of hormones. That's the starting place. Of course, you can change the ratios and all that. But I've since spoken to other women who have different, or other doctors also have different prescribing methods as well. And they would say, well, we prefer the more potent estradiol, and they would not prescribe bias. In fact, some of them say, I don't even like bias. But you've got what, like nearly 4 decades of treating women in menopause. I'm sure you're seeing results. Why aren't the others seeing the same?
Well, it all began with the medical doctor that really popularized bioidentical hormone treatment in the United States, Dr. Jonathan Wright, a brilliant and very humorous and wonderful man. And his basic theory was, if we're going to replenish hormones, why don't we copy nature? Why don't we try and replicate by treatment what's actually in a woman's body? So he had done some studies on Premarin, and that was the most popular estrogen of the day, and it was derived from horse urine. That's a good industrial way to handle it. To get a large quantity, you get a large quantity of horse urine, and half the hormones in horse urine are seen in the human female. Half of them are not. They're only unique to horses.
Mm.
But it was a reasonable attempt to treat. Premarin, most popular and profitable drug of all time up to the Women's Health Initiative. He said, I don't know about the 50% of the estrogens that are in that Premarin that a woman's body has never seen. Why don't we copy nature? Isn't there any molecules that are identical to what's in a woman's body? And there are. And it turned out that the pharmaceutical manufacturers had gotten into this to produce the large quantity of birth control estrogen.
Hmm.
And what they did is they extracted from plants a precursor called diastegenin, and they biochemically converted it to estradiol, estrone, estriol of the estrogens, testosterone, progesterone, DHEA, same molecule. That was one of his principles. Use the same molecule. Don't use molecules that are different, that could have toxic potential. Use the identical molecule to what's in a woman's body. Now, he also knew a lot about the family of hormones called estrogens. There is no hormone called estrogen. That's a family name.
Hmm.
There's three principal estrogens that have activity. Estradiol, that's the most potent estrogen that comes out of a woman's ovary. But it's not the most prevalent. There's two plus times as much estriol. I'm sorry, estrone, which is a byproduct of estradiol, and it has potency. It's about 80% as potent as estradiol. And there's a third hormone that's present in more quantity than the estradiol and the estrone. It's called estriol. This is present in a woman's body. So when you do a 24-hour urine, which was the gold standard back when he was being studied, as it is today, you see there's more estriol than there's the sum of the other two estrogens. So Dr. Wright said, I think we should copy nature. Let's not invent a new pattern here.
Hmm.
Let's give women what produces the pattern that is found in young women. And he experimented around and he chose two of the estrogens, estradiol and estriol. And when he administered 80% estriol plus 20% estradiol, that's biest,
Hmm.
two estrogens, he was best able to replicate the urinary hormone profile of young, healthy women.
But why wouldn't Triest work? Because,
Well,
like you said, we
he
have all
started with
three.
triest, but he wasn't getting the same results. And he learned that he would get the best results if you just gave estradiol and estriol. The goal, young women, when you examine their urine, they have certain hormone profiles in there.
Hmm.
And what he was trying to do was replicate what a young, healthy woman looked like. And when he tried Triest, he couldn't get the pattern right. When he went to estradiol and estriol alone, 80% estriol, 20% estradiol. That, for most women, not all, there are exceptions, but they're not that common. That would reproduce the pattern that found in young, healthy women.
Hmm.
Now, he didn't do that just out of nowhere. He was familiar with a medical doctor, a cancer specialist named Henry Lemon, who in the 1960s was studying the breast cancer. And he wanted to know, was there a hormonal component to it? And he took the urine and did 24-hour urine hormone testing on young, healthy women. And what he found on the average was that the young, healthy women had 1.3 times as much estriol as they did the sum of estrone and estradiol. And when he took the urine of women who had breast cancer, he found that it was way less than one. There wasn't much estriol. It's way less estriol. It turned out I got commissioned to repeat this study and funding in 2010. And instead of getting an average of 1.3, I got zero point 0.9. And that was the average. There was zero point 0.9, there were 9 tenths as much estriol as there was as the sum of estrone and estradiol. In other words, there was more estriol than there was estradiol, about twice as much, and there was more estriol than there was estrone, just a little less than twice as much.
Hmm.
Lemon got 1.3 in the late 60s. I got zero point 0.9 under very scrupulous conditions in this study. Took me 2 years to do it. So Dr. Wright proposed that we treat with biased, and he suggested 80-20, at least to start with. And that replicated what young healthy women look like. Now, in the 1990s, this is a big story. I hope it's not too boring to people.
No, no, tell me.
In the 1990s, estrogen receptor sites were discovered.
Hmm.
When Dr. Lemon was working and Dr. Wright in the 80s was proposing use bias, there was no knowledge of estrogen receptor sites.
Mm.
And here's what they learned, that you could break down a woman's menstrual cycle into two different phases. From day one to about mid-cycle, it's all about proliferation. It's all about buildup. It's all about proliferation through cell division of the lining to the uterus so it could get rich enough to receive a possible fertilized egg. Proliferation. That proliferation is also occurring in the breast.
Mhm.
The whole first part of every single menstrual cycle, a woman is also preparing for breastfeeding. Holy mackerel. Couldn't it wait a couple months? Well, no, the original design is it's occurring every cycle. And many women feel this. They feel their breasts getting fuller as their cycle progresses. There's more cells there. There's brand new cells that have occurred by cell division there. Proliferation in the uterus of the lining, proliferation, cell proliferation in the breast in preparation for possible lactation. If the woman does not get pregnant, there's a second half that cycle is all about de-proliferation. Eventually, the cells in the uterus shed and are menstruated out.
Hmm.
And the cells in the breast disappear by a wonderfully named process called apoptosis. And women's breasts sooner or later get less full. And they go through that cycle of proliferation, first half of the cycle, de-proliferation if they don't get pregnant,
Hmm.
second half of the cycle.
Hmm.
Well, when the estrogen receptor sites were discovered, what they learned that was two major receptor sites. One is called ER alpha. That's all about proliferation. Whenever a hormone interacts with ER alpha, here's the receptor site, here's the hormone, that interaction causes proliferation. ER alpha, stimulation, proliferation is the outcome. And if there's no implantation, the second half of the cycle is under the direction of ER beta. It's all about deproliferation. Interaction with ER beta causes deproliferation.
Hmm.
ER alpha is primarily under the inspiration of estradiol, the most potent of the estrogens. ER beta is primarily under the inspiration of estriol. So even though Dr. Wright and Dr. Lemon before him, they didn't know the reason because the receptor sites hadn't been discovered, we now know that estradiol is proliferative and estriol is deproliferative. And what do we want in a midlife woman? We don't want proliferation of breast glandular tissue in a midlife woman.
Hmm.
We don't need it. Now, there's been theories out there that all you have to do is give a woman estradiol and she'll make enough estriol. Well, I can tell you that is wrong. How do I know it? I had that theory for 2 years. A doctor friend of mine in the early 2000s says, you don't need to give women bias. Just give them estradiol. They'll produce it. And I was doing 24-hour urines. And I gave a certain number of my patients estradiol instead of biased. And I looked at the patterns of hormone output in the 24-hour urine, and it did not produce anywhere near the estriol that is nature produces in a young, healthy woman. Well, I'm a believer as the bottom line in midlife do no harm medicine with hormones is don't do anything that adds to risk.
Hmm.
And proliferation and increased breast density, that does add to risk. So use nature's design. That we're not inventing. We always say, don't invent a new woman. It's been a great job has been done here.
But how, in terms
Copy
of
nature.
if estriol is de-proliferative, if it's breaking down what estradiol is bringing up, how does it compare to progesterone? Because we always say progesterone is also what balances things out and helps us shed the uterine lining, among many other things, in terms of balancing that out.
Well, you're bringing in the rest of the design. The bias does not stand alone.
Yeah. But I'm
Testosterone is an
wondering how much
amazing.
it compares, like in terms of power. Is it really the
Oh
estrogen
yeah,
that's
it's
doing all that heavy lifting, or is it
I mean,
progesterone?
progesterone does so much. And just take a look at a woman's body.
Hmm.
When in the third week of her cycle, she produces 100 times more progesterone than she does estrogens.
Yeah.
We don't have to know the reason, but why not just copy nature? Because that's what a woman's body likes. And this is a different type of balancing that occurs. Estrogen is a great stimulator, stimulates breast glandular tissue, stimulates endometrial, it awakens the brain. Have awake brain, you need estrogen. Stimulates hair growth. It's like fertilizer for young. Look at a 14-year-old, 16-year-old young woman's hair, for example. So many cases. Estrogen stimulates. Progesterone is the great calmer. Young women who have anxiety, they're so often they're not getting enough progesterone for reasons. And you give them progesterone and the anxiety goes away. You don't give them Xanax, you give them progesterone because
Mhm.
it's the great calmer. So it balances estrogen in other ways. The whole bias story is biochemistry and physiology all of its own.
Yeah.
And we're not trying to do anything. We trust the original design. That's the thing. And we're just trying to not invent a new design. And if you don't use bias, you do not produce what a young, healthy woman does.
Yeah. Yeah, I think it makes sense. I mean, we all want to go back to nature and what's natural, but like was proven is trieste, even though that's what women were producing, it doesn't always work out. It doesn't always pan out that way. So I
It
think
doesn't at all.
we're trying to
Yeah.
reproduce, but we probably have some limitations as well. It's not like we got to probably sit within certain parameters of a menopausal woman. Maybe trieste would work for a woman who's had surgical menopause in her 20s. I don't know.
The thing is, it's not necessary because all of these hormones convert to one another.
Mm,
And to reproduce the pattern that's seen in young, healthy women, if you do triest, if you produce estradiol and estrone and estriol, you don't get the pattern. As soon as you omit the estrone, which is just an intermediary step, how it goes is estradiol goes to estrone, goes to, through a couple steps, estriol.
hmm.
If you omit that intermediary, all you have to do is give estradiol and estriol, and you'll reproduce what a young, healthy woman.
Hmm. Yeah. Okay, so we don't need. That's why, yeah, nobody uses estrone anymore. Or
Yes,
I
right.
haven't. Yeah, I don't meet anybody who uses that. But let's move on to some of the delivery methods because we did cover this already in another episode. We talked about the most used methods of delivering hormones are the creams, gels, patches, oral, even the organic oils that you have, pellets and injectables. These are kind of all out there that most people know of. But I'm wondering if there's any emerging technology for new delivery methods of bioidentical hormones.
Well, there's everything, there's all kinds of delivery methods, and there's only one that's acceptable to me. And like, it's a mistake in the world of hormones to give someone an oral hormone, give someone by mouth. There's an exception to that. Progesterone and DHEA you can give by mouth. I don't hold that to be ideal, but they work. But not estrogen by mouth.
Mhm.
Estrogen by mouth increases the risk of blood clots. And there's technical reasons why this is so. And testosterone is not even safe. A woman is at risk for liver damage. Although there's new kids on the block, testosterone by mouth, but I'm not seeing the kind of results that I'd like to see with it.
You mean like troches,
Well,
sublinguals?
troches are different. Troches go under the tongue. They go right into the bloodstream. But I'm talking about pills like Premarin
Okay.
or estradiol pills or the birth control pill.
Hmm.
These are given estrogen by mouth. They're swallowed. You have to give a lot more because 80% of it gets degraded by the liver right away. I'm going to give you the short version. Don't take hormones by mouth. Maybe an exception of progesterone and DHEA.
And how I'm wondering the troches are because I have just very few people I met who use troches for testosterone. Does it bypass the liver or does it stay
Well,
in your
have you
mouth?
ever sucked on a gummy?
Yeah.
You know, it stays there for a while.
Yeah.
And some of it does get absorbed under the tongue directly into the bloodstream, but you wind up swallowing a certain amount of it. So you can get imprecise dosing.
Yeah.
And that's why I'm not a fan. Plus, I'm not a fan of any kind of rapid intake, like injections. Men have been injecting testosterone forever. Some women even inject testosterone.
Mm-hmm.
That gets the levels up too high too quickly. Goes right into the bloodstream almost. So
Mm-hmm.
I'm not a fan of anything that jacks those levels up. Whereas, let me cut to the chase. The optimal way for these ovarian hormones is topically, rub it into the skin. They work beautifully and they're nice, slow uptake, very gentle, and they don't provoke things. You give a man an injection of testosterone, his testosterone goes so high for a while, it increases his red blood cell count,
Mm-hmm.
it increases his estradiol, it increases, but this is well known with throughout treating males.
Mm-hmm.
We don't like spikes in hormone administration. Cut to the chase, topical works wonderful.
But we usually, when somebody, the people in my community, once the ones who are taking injectable testosterone or even injectable estrogen as well, or estradiol, they say it's because the topicals wasn't working, the patch wasn't working. They were so frustrated. I mean, who wants to inject themselves? But it seems as though
Well,
that they
yeah,
get there are certain part of the population that just sort of have
but
to.
you gotta look at the individual. If it wasn't working, something's wrong and it's there to solve. And I'll get to that in just a minute because your first question was really important. So topical application of hormones became really popular with the bioidenticals in the 1980s. And in order to give the same dose every single time, you take the hormone and you put it into a bottle that has a carrier in it, it's called a gel or a cream.
Mm-hmm.
In fact, what's ever in a jar or a toppy click is over 99% gel or cream. And forever, since the 80s, when this was being done in mass by compounding pharmacists, the gel or cream had to be strong solvents. In order to get the hormones up into solution, so that every time you clicked something or you scooped out an amount or you hit a pump, the exact same dose would be there throughout the whole bottle, had to be in a solution. But any chemist knows who studies steroid hormones, they do not dissolve in water. And they are very poor dissolvers unless you use a strong solvent. So I'm going to jump to a whole other topic. When I was in high school, a lot of the young women weren't menstruating or weren't having breast development. It was well known amongst us young boys. And nowadays, you got young girls that are menstruating at 11, 10, 9. They're
Mm-hmm.
getting breast development at 8 and 7. What is the difference in human history that would allow that kind of stuff to happen? It turns out that so much of the toxic substances that we put in our food supply, principally those that derive from dinosaurs, otherwise known as petroleum products, they are toxic to the human body. And how do they behave? They're estrogenic. They
Mm-hmm.
cause estrogen. So you've got a whole generation of women that are getting estrogen substitutes
Mm-hmm.
prior to their own estrogen being produced, and they're getting breast development from these estrogen-like xenoestrogens, they're called, as you know, and they're in the fertilizers because these are derived from petroleum, the pesticides and herbicides,
Mm-hmm.
and all the products that you were mentioning. They've got solvents in there.
Yeah.
And so I became a functional medicine holistic doctor in 1968.
When it wasn't a fashion, like when there was
Wasn't
no
the,
one, you were one
there
of the
was no
first.
name. There was no name for it.
You were probably number one.
And what I started exploring is what causes all these illnesses. And it got down to indiscretions of nutrition,
Hmm.
indiscretions of exercise, too much or too little, toxic exposure, poisons in our environment,
Hmm.
and a dysfunctional response to stress. So I grew up on toxic exposure and detoxification procedures
Hmm.
to get some of these things that absorbed into our body out
Hmm.
through
And it's like a
sauna.
hundred times more, if not thousands times more nowadays than back then.
Yeah.
But I'm wondering then, so just to play a little bit of devil's advocate, you mentioned, well, if girls are getting breasts and their hair and everything is developing at age 9, 10, 11, much earlier than before, we just talked about how estrogen's protective. Why is this a bad thing?
Well, nature's design of estrogen is beautiful. These are not protective estrogens. These are hormone disruptors. They interact with the receptor sites, but not like your ovaries estrogen. They're not the same. They're toxins. This was dramatic for me. I had been prescribing to women in menopause for 10 years and I had never seen a hormone. I would call in a prescription to my compounding pharmacist and he would ship it directly to the patient. And one day there was a misshipment to my patient. It came to my office. It came in a white jar, biased in a white jar. And I was fascinated. I had never seen a hormone. I cracked,
Prescribing this and you had no idea what it would look like.
I didn't. And I cracked the seal and opened up the top of the jar, and out comes this strong odor. And I was puzzled by that odor. I wondered what it was. And I started looking up the ingredients of the base, the stuff that the hormone was put in, and learned that they were strong solvents with these long chemical names that people read, but they don't, what the heck is that? And I did a bunch of research on it and I saw their toxic potential and I did some math and I realized I'm detoxifying my patients. And at the same time, for the women in menopause that I'm treating, I'm suggesting that they put a quart of this stuff on their bodies every year for 10, 20, 30, 40 years. What's wrong with this picture?
Yeah.
And I was a little bit shocked. And my son and I went on to do a lot of research and we like organic stuff. We always have. And so we're after a bunch of research and a bunch of testing, we developed an organic oil
Hmm.
to put the hormone for the pharmacist to put the hormones in.
Yeah. It's a brilliant
And it's
idea.
certified organic oil, and that's what we use. Now, there's no solvents in there. So what you have to do is you have to shake the bottle before
Ah.
you use it. It's a suspension, so every time you use it, you have to shake the bottle a few times.
It's a little effort for having something much better for your body and non-toxic. And I think it lists in Europe. I still, wherever I get a doctor in Europe, I'm like, I want organic oils, or they have no idea what I'm talking about. They say we don't do this. So if anybody's listening in the US or maybe Canada, they can find out through maybe the doctors you've practiced or you've taught to be able to order this stuff, right? I mean, can they go to any
Well,
of their
we're
practitioners?
working on Europe.
Oh, yay.
We actually spoke with a pharmacist in Madrid
Oh,
a couple of years
yoo-hoo.
ago, and she didn't bite.
Oh, I
But
have one in Barcelona who
great,
I met at the European Menopause and Andropause.
fantastic.
I will
Please,
connect you.
yes, please. So
She studied with Dr. Louise Newson, so she's on the ball. Yeah.
and I'm a personal colleague of Dr. Newson, and I've spoken to Dr. Newson about the organic oils. Because Great Britain is the place that we're closest to getting it in.
Oh,
We train
fantastic.
physicians in Great Britain.
Oh, you have.
Yeah.
Okay, we need that
So
list.
anyway, the bottom line is all of us want to do the safest, best stuff. And I'll tell you, if a patch or Premarin was the only, or injections or pellets were the only tools I'd have, I'd use them. But you don't need to use them because right now there's the organic oil, there's bioidentical hormones, there's knowledge on how to get each individual woman's balance proper for her. Must individualize. This is not a one dose fits all thing. And if you do those things, you get happens. You get the best outcome.
Yeah.
And you get the most satisfied, grateful, happy, even ecstatic women who they're on the right path, they know it, they feel it, they got themselves back, and they're on a cruise for the rest of their lives. Just like the last day that I'll take my testosterone, as I did after my shower this morning, is when I can't, they have to rip this bottle out of my hand. If I can't shake this bottle, that'll be that's only going to be my last day. That'd be the only reason I couldn't shake the bottle anymore.
Unbelievable. Well, we have to wrap up because I've taken already so much of your time. I'm so grateful. I have a whole other list of questions, but we're going to have another part five with
Excellent.
you. It's so fun to speak with you, and I always learn so much. And I highly recommend everyone to check out the Menopause Method program, and especially if you're a practitioner and you need help getting some training, I'll have links to that and the Institute of Bioidentical Medicine as well. Fabulous program that you created. But I will have also links in the show notes to get your free book, Healthy Happy Hormones, and the Facebook Menopause Doctor. You nailed that on Facebook and Instagram. You got Menopause Doctor. It's just absolutely brilliant. And before I wrap this up, is there any last words you'd like to share with us or things that are coming out in your world you'd like us to know about?
Well, I think the most important for any individual woman is to really see that the fright, the scare around risk was incorrect. And there is great science. And the great science is women who are treated with hormones are at less risk for breast cancer, heart attack, osteoporosis, cognitive decline, stroke,
Genitourinary syndrome of
and,
menopause,
and a long
muscular
list.
syndrome of menopause.
That's that's the actual science, less risk.
Yeah.
And that each individual woman, you don't have to go to medical school for this. You could learn, I assert you could learn everything that's important for you to know by reading my book, Happy Healthy Hormones, which you can download a free PDF copy of. But that's not your biggest job. Your biggest job is to go shopping. Reach out, find out who in your state or your country. Because with telemedicine, they don't have to be in the same city anymore,
Mhm.
is good at hormones. Interview people, ask your friends, ask compounding pharmacists, who's good at this?
Mhm.
And keep shopping until you land with a provider that you really like and trust. I recently did this myself around ophthalmologists. I went to 4 eye doctors and I knew I need cataract surgery and I just didn't feel right. And
Mhm.
I kept pounding the pavement until on the fifth ophthalmologist, within 5 minutes of being with him, I went, there he is. He's my person. I went shopping. It
Yeah.
was an effort. It cost a little more money than I would have liked to have laid out. But that's your job until you get someone that you go, this is great.
Hmm.
And
And
then they'll
you'll,
write prescriptions and together you'll team it and you'll figure it out and you'll be on a cruise for decades and decades and decades.
mm,
And maybe even retain your libido and your active sexual life into your 80s, like women and men that I know. This is fun. Think about that. It's a good thing.
and it's important, very important.
Yeah.
Wonderful. Well, I appreciate your time and we'll have you on again for sure. And everyone who's got to the end of this podcast, thank you for listening and tuning in. And I'll connect you. If you, Dr. Rosensweet's trained many doctors. So if you like his method, we can find a doctor for you as well easily. And if you're international, I have a whole blog article on how to find doctors internationally as well. So thank you so much and have a wonderful day.
Thank you, Zora. So good to see you.